Welcome to How To for Dermatologists. I'm Neil Bhatia, your host. This is a series on helping to make some practical decisions from experts in the field and helping us take some better care of our patients. And I'm with Dr. Aaron Bowe, Dr. Mark Lebwall, and today we're going to talk about how to choose the optimal biologic for psoriasis. And Aaron, you've done a lot of good research on how to choose biologics, where do biologics fit. Tell me about some of the things you decide on, how to make a biologic work for that patient.
Well, when you're in a busy clinic, you want to do something quick. So I've summed up with like 4 factors that I look for in terms of getting treatment choices. I look at BSA, or extensive disease, comorbidities, past responses to therapies, and accessibility to the drugs.
So let's take insurance and access aside. Where does a patient with, say, 20% surface area or scalp and nails, where do you kind of go to when you're thinking about biologics?
Well, you're going to look at BSA. If a patient has greater than about 10% BSA, you know that's moderate to severe psoriasis, and that needs to be treated with systemic therapy. But there's other situations where you don't have quite that extent of disease, but the area of involvement is significant and causes some severe problems.
So Mark, when you're thinking about patients who've tried and failed other treatments, what's that failure time frame? How long do they have to fail something before they move to the biologic stage?
So I will say some of the drugs work very quickly, the IL-17 blockers, for example, and some of the drugs are slower getting there. The TNF blockers are a little bit slower, with the exception of infliximab, which is pretty fast. The IL-12/23 blockers are a little bit slower than the IL-17s. So I usually don't give up until about 3 months. I usually wait until about 3 months before I can conclude that a patient's not going to respond.
So walk us through this table. We've been discussing some of the other criteria for psoriasis, some of the comorbidities. Where do the classes and the comorbidities kind of match on this table?
Well, I think importantly, one has to look for psoriatic arthritis or the risk for psoriatic arthritis. We also like to consider things like obesity as well as inflammatory bowel disease in the light of these new IL-17 drugs that have come out. So I think asking questions about those sort of comorbidities will kind of focus on which the best drugs are to choose from.
So what is it about the IL-17 class of inhibitors that impacts inflammatory bowel disease?
Well, we know that the IL-17 inhibitors or the IL-17 receptor inhibitors as a class will all have a tendency to exacerbate or induce inflammatory bowel disease. Even though that incidence is extremely low, you don't want to risk that for a patient.
And what about criteria like cardiovascular events or history of malignancy? Where do those fit in?
Sure. There are actually many comorbidities and many historical items in a patient's health history that we consider. I think Aaron hit on the most important one. Psoriatic arthritis, of course, will influence us. We know the TNF blockers are the gold standard for that. Recently, the IL-17 blockers have been shown to work quite effectively in that setting as well. Obesity has a big impact. Some of the drugs that are modestly effective are not nearly as effective in obese patients. So that impacts my decision of therapy. But there are actually many other factors as well. I once was in a room with about 50 patients, and I asked them all to stand up, and then I went through, and I did them all at the same time. How many have had any of these? Psoriatic arthritis, been overweight, had a history of diabetes, hypertension, cigarette smoking, family history of heart attacks, congestive heart failure, tuberculosis, hepatitis B, hepatitis C, multiple sclerosis, positive ANA, lupus, and how many of you are women of childbearing potential, which impacts my decision. And all of those factor into the drug that I'm going to pick.
Yeah, and we were just talking about TB a second ago, about the patient who has latent TB or a history of TB. Where does that fit into the decision tree?
Well, having a positive PPD or latent TB is not an exclusion to treatment for any of these drugs. What you have to do is screen for it, and if they're negative, proceed with your choices. If it's positive, you make sure that the patients are treated for latent TB or it was a false positive test. The only real contraindication, I think, at a point in time with these drugs is if you would happen to have active TB. That needs to be treated before you're going to embark on any of the biologics.
Excellent. So in the last 30 seconds, what kind of pros would you share with the audience?
I would say every patient's individual, and what you need to do is go through an extensive history with the patient. Usually we get that in our review of systems, and it'll guide you as to which drug you should be using.
How about Aaron?
I think that Mark's hit it on the nail on the head. You really need to make sure you know the patient and the patient's individual problems to pick the right drug, because the drug will only work well in the right setting. And so I think that's the most important thing, is to know your patient and realize that there's not one drug to treat this disease.
That's excellent. Well, Erin, Mark, thank you. Thanks for helping our audience choose the optimal biologic for psoriasis, and we'll hope to see you again on the next episode.